Acute and chronic gastritis, two distinct entities, both centered around inflammation of the gastric mucosa, but with very different mechanisms and consequences. Start with acute gastritis. This is a sudden, often transient inflammation caused by things that aggressively disrupt the gastric mucosal barrier. Think NSAIDs, alcohol, severe physiologic stress like burns or ICU trauma, and yes, even H. pylori. The pathophysiology? Simple but devastating. Damage to the protective barrier allows acid to injure the stomach lining. Clinically, you'll see epigastric pain, nausea, vomiting, and in more severe cases, hematemesis. Now, shift to chronic gastritis, and we divide this into two main types. Type A is autoimmune. It affects the fundus and body of the stomach, where the parietal cells live. Autoantibodies attack those parietal cells and intrinsic factor. Result? Intrinsic factor, vitamin B12, pernicious anemia, and here's the kicker, it also increases the risk of gastric adenocarcinoma. Type A is A for autoimmune and A for the top of the stomach, the fundus and body. Type B, on the other hand, is caused by H. pylori, and this chronic infection leads to increased risk of peptic ulcer disease, malt lymphoma, and yes, gastric adenocarcinoma as well. So, quick contrast. Type A, autoimmune, body fundus, B12 deficiency, adenocarcinoma. Type B, H. pylori, antrum, ulcers, lymphoma, and also adenocarcinoma. Two types, two pathways, both with high yield implications. Peptic ulcer disease is a breach in the gastric or duodenal mucosa due to acid and pepsin. High yield? Absolutely, and commonly tested. The most common cause, without a doubt, is H. pylori infection. Others include NSAIDs, smoking, alcohol, and in rare cases, Zollinger-Ellison syndrome, where a gastrin-secreting tumor drives acid hypersecretion. Don't forget stress ulcers in ICU settings, curlings after burns, Cushing's from brain trauma. Now, let's break down the types. Duodenal ulcers. These are more common, and here's the clinical pearl. Pain improves with food. Why? Because food temporarily buffers the acid. Importantly, duodenal ulcers are almost never malignant. Contrast that with gastric ulcers. Here, pain gets worse with food because food stimulates acid secretion, aggravating the lesion. Gastric ulcers are less common but carry a real risk of malignancy, so always biopsy. Always. Complications? Classic board fodder. Bleeding is the most common, leading to hematemesis or melena. Perforation causes sudden, severe pain with free air under the diaphragm on X-ray. Gastric outlet obstruction, think vomiting and a succussion splash on exam. Penetration means the ulcer bores into adjacent organs, often the pancreas, causing back pain. Diagnosis? Start with endoscopy, the gold standard. For H. pylori, use the urea breath test or stool antigen. And again, biopsy any gastric ulcer to rule out cancer. Treatment depends on cause. For H. pylori, give triple therapy, PPI, clarithromycin, and amoxicillin or metronidazole for 14 days. For NSAID-induced ulcers, stop the NSAID and start a PPI. Bleeding ulcers need endoscopic hemostasis and IV PPI. And a perforation? That's a surgical emergency. Don't wait. Duodenal versus gastric, H. pylori versus NSAIDs, benign versus malignant. The distinctions aren't just academic, they're life-saving. Q1. A 45-year-old man presents with epigastric pain that improves with eating. He's a smoker and regularly uses NSAIDs. So, what's the most likely diagnosis? Duodenal ulcer. That classic better with food clue? It's gold. Answer B. Duodenal ulcer. Q2. A 60-year-old woman has long-standing anemia, glossitis, and anti-intrinsic factor antibodies. Endoscopy reveals fundal gastritis. What's her highest risk? Gastric adenocarcinoma. Type A autoimmune gastritis knocks out parietal cells. Down IF, down B12, down pernicious anemia, and eventually neoplasia. Answer C. Gastric adenocarcinoma. Q3. A critically ill ICU patient develops melena and is diagnosed with acute gastritis. What's the best prophylaxis? IV PPI. It's first line for stress ulcer prevention in high-risk ICU patients. Answer A. IV PPI. Q4. A patient has recurrent ulcers that don't respond to standard treatment and elevated fasting gastrin levels. What's the next step? Secretin stimulation test. It confirms Zollinger-Ellison syndrome by checking for paradoxical rise in gastrin. Answer B. Secretin stimulation test. Q5. A 58-year-old man with a known gastric ulcer presents with sudden, severe abdominal pain and a rigid abdomen. X-ray shows free air under the diaphragm. What's the next step? This is a perforation. You go straight to emergency laparotomy. Answer A. Emergency laparotomy. Now, rapid recall on drug regimens. H. pylori, PPI plus clarithromycin plus amoxicillin or metronidazole for 14 days. NSAID-induced ulcers, stop NSAID, start a PPI. ICU prophylaxis, PPI or H2 blocker. Know the patterns, know the complications, crush the boards.